from Kuala Lumpur would be joining it at 2 o'clock. We've now adjusted that to he'll be joining us right after lunch at 1:15. We had a little miscommunication amongst us about Kuala Lumpur versus Hanoi time zones. But we've pivoted successfully there. So I want to shift the conversation now. In our next session, I'll discuss general data requirements necessary to successfully manage health insurance business. And this is not a trivial matter at all. And if there's one thing I'd like you to take away today, it's the need to for you and your company, your insurance company, to do the work to build robust claims data sets to use in managing your health insurance business. It's necessary not just for premium rate setting, but for many other reasons. Risk management, we talked about fraud detection a little bit earlier. You really need quality claims data to do the analytics to identify potential cases of fraud. None of it is possible without a robust, granular data set. And I'll note, just to provide some context and perspective, the only reason I note this, an emphasis on quality data is an important aspect of our business in Milliman and the health actuarial work we do in Milliman. We emphasize in our promotional materials and talking with clients and business development the amount of work we do to obtain, maintain, and be able to do analytics on healthcare data. And this is literally a true statement. I'm sorry, I keep turning away from the mic. Is this all right? It's the online people that are having problems, right? And I'm not saying this because I'm trying to sell you anything. I just want you to understand. My firm, Milliman, we literally spend tens of millions of dollars a year on healthcare data. And we're not even an insurance company. That's the strategic value of healthcare data. It is by far the single largest item that we spend and invest in the healthcare area in my firm. In addition, I'll note that within Milliman, we have an entire business unit within our health practice area that does nothing but help clients develop and maintain robust claims data sets. That business unit is not just some small little sideshow. It is one of the largest business units in all of Milliman. That business unit does over $100 million a year in revenue, focused exclusively on developing and maintaining robust healthcare claims data. And not just for actuarial needs, but to support all sorts of management decision making. So the data quality is widely accepted across the industry, an area of key strategic importance. So that said, let's talk a little bit about the basics. And I'm going to talk about the kind of data at a very high level, the highest level, the kinds of data that you need to, and a health insurer needs to be capturing in an accessible and quality way. One is obviously policy data, information on what your products cover, information on your policyholder distribution. Claims data for actuaries, this is the big one. And I'm not just talking about the general ledger in your accounting department, how much you spend on claims. Having good granular detailed data, preferably at the insured member level, on frequency, severity, type of service, the dates of service. These are, it might be just the bare essentials. The more granular and clean that data set is, the better it will be for managing all the business in the company. Again, more than just for pricing purposes. Exposure. So in addition to claims, we need information on the lives covered. How many, when they were enforced, and so on. Because you can't really fully evaluate claims data unless you know how many people you were covering. There'll be some external data that is really important to get your hands on, such as external trend data. Sometimes epidemiological information can be useful to the actuary. These can be useful in making judgments and setting pricing assumptions. And finally, demographic detail on the enrolled population is necessary. Age, gender composition of your enrollment can help not just in setting premium rates, but in benchmarking, interpreting claims history. Geographic location may be relevant depending on the market. Some insurers also gather socioeconomic information. And it might be as basic as the industries in which their insured members work. I'd say that's less common today than it used to be, but there's historically a clear pattern of employees of certain industries have higher or lower costs than average. So data preparation, which is the careful review and cleaning of data necessary before use. Raw data that you just have in your files can have a lot of problems. And so, raw data can be, it's noisy and it's dirty in practice. There can be inconsistent, it can be incomplete, there could be duplicate claims, there could be claim payment amount that don't make any sense. It's not uncommon to see in the raw data file claim payment amounts of 0 or even negative amounts. And so there's a whole science to how you turn the raw data into usable by actuaries and usable by management data for managing the block. And if you don't do the work to turn your raw data into relatively clean quality data, doesn't need to be perfect, by the way. Perfection is, you'll never achieve it, but it needs to be good enough. If you don't do that work, you can have problems in which your work leads to misleading results, poor pricing, and so forth. So the steps involved in data preparation for pricing, as I mentioned, data preparation helps turn the raw data into usable pricing inputs. And in addition to cleaning the data and getting making sense of the nonsensical or difficult or missing information, you've also got to link the membership. You've got to link claims, you've got to link policy data, and there's other information. You've got to link all those together in a way that makes sense, so that you can, summarize your exposure and your costs and prepare the data then for further analysis in the future. So the main data sources for medical pricing, as I said, the membership and policy data coming from your own systems is who's covered, when were they covered, or are they covered, and by which product are they covered under, and maybe capture some demographic information. What is their age? Are they male or female? If relevant, you might capture the part of the country that they live in, and so on. Claims data, and again, this is the basic, is what medical services were used, when were they used, where were they used, and at what cost. You need this claims data for more than just the act of paying claims, although that's important too. To the extent that you have uh, negotiated arrangements with hospitals and physician groups, you need that information. You need the fee schedules or the discount rates, agreed to prices, reimbursement schedules, and so on. And then there can be external data that is relevant. Um, this could be population statistics, um, the any information that's made available by the government on inflation, um, any information that's broadly available across the industry on medical cost trends, and so on. So I've got this slide here, clean claim data. It's a single slide with just a few bullet points on it, but I will say this is a huge and complex area. Um, so clean claim data, as I noted, contains member information and information on the claims themselves, service category, meaning type of service, inpatient, outpatient, billed and paid amounts. And as I mentioned, common issues in the data can be negative amounts, zero amounts, claim dates that are outside the coverage periods, duplicate claims, and so on. Real world raw claims data is messy. Um, and so there's a whole chain of decisions and adjustments that need to be made. How do you, so it's not uncommon for a claim to come in and it gets paid, and it was realized it was paid in error, so a second payment, or there may be a small refund back, and so on. And each of the one of these is a separate ledger entry, and so it can create all this mess. And what do you do with that? And sometimes there are just obvious errors in the claims data. That just happens because everybody is human. Um, and you've got to figure out how you want to handle those. Do you exclude them, or do you put some proxy in, and so forth? As I said, I mean, essentially what I've covered here is an entire industry. So let's talk a little bit about what can you do, or what happens if you don't have much data? And when I say data, I'm talking about either your own company's historical claims data, or a reliable, clear, clean outside source. Um, so what do we do in these situations, which is very common? Um, the there's a a whole bunch of possible ways to find other data. There may be industry data that's available, maybe. There may be government studies that are available. Um, there may be population data that is available. Of course, I would include the standard actuarial caveat that the numbers associated with the general population may be quite different than the numbers than the healthcare claim cost patterns you receive by an insured population. The insured population is not a random sample of the general population, and will likely have some skewing for a variety of reasons. And so forth. There may be some proxy measures. I've heard of, in certain cases, of surveying hospital systems or even surveying policyholders for certain key pieces of missing information. Um, there may be related data available that you can use. So if you're looking for hospital days and you don't have hospital days, it's not available, but you have hospital admissions. It's not the same, but it's a step. I talked about credibility adjustments in pricing methodologies, with the same concept applies here. Is, if you've got limited internal data and so you want to augment it, and strengthen it, but not totally replace it with some external data, then you want to be able to make adjustments according to judgment and blend that data appropriately. And my last column here, because I'm an actuary, I say you should make conservative assumptions, err on the side of caution. And when, like, the rule of thumb is the further your data gets away from the population being insured, the more uncertain it is, and therefore the higher risk it is, and therefore merits higher degree of conservatism. All right. So what, again, on little or no available data, a little bit here about what to do about it. And this, as I mentioned earlier, I've heard this come up quite a bit in my, so far this week. What you can do about it is develop the discipline and make the investment within your own company to build quality historical claims experience data. Standardizing processes, standardizing data definitions, and investing in systems and expertise to make that happen. There's no magic wand. There's no way to do it other than doing the work. In the meantime, you will need to exercise professional judgment as an actuary. And in exercising professional judgment, you should solicit the input from other professionals in your organization. That could be talking to the manager of the claim department, for example, having conversations with medical underwriters about the trends they're seeing in the business they've reviewed in the past few months, and so on. That is just anecdotal. It's not data, but it's anecdotal information. But it can be really useful, especially coming from somebody with real expertise that you trust. It can be useful when you then make informed judgments about pricing. And then finally, you'll hear me talk about this later too. Whenever you're using uncertain data, it's paramount that you test sensitivity. So if I'm setting my pricing based on a certain set of hospital costs, say hospital utilization and hospital days, hospital cost per day, that sort of thing, assumptions, and it's coming from an external source. I've had to make a lot of adjustments. In other words, the possibility that is wrong or deviates from what will actually happen is higher. Then you should be sensitivity testing. What does it do to our rates? What does it do to our expected profitability? If I was wrong, if I underestimated costs by 10% by relying on this data, and so forth. So the key takeaways on data, you need clean data to effectively and appropriately manage health insurance business. In my mind, there's no intermediate ground. Clean data does not mean perfect data. There's an old saying we use, don't let the perfect be the enemy of the good. Strive for the good and then strive to improve as you go along. In gathering the data, you should focus on clarity. So a well-defined, clear unit of analysis. So in my experience, we typically use a quote-unquote PMPM amount, a per member per month. So member is per insured member, per person enrolled in the insurance program, and per month, because we're typically charging monthly premiums. You need clean membership data, clean claims data, and focusing also on the linkage between those two to make sure it's airtight. or as much as possible. And then finally, you want to check the reasonableness of your results and sensitivity test. Okay, that's what I have prepared on data. And I'll pause there and ask if there's any questions.
This is not a daily question, but there was an online question on the methodology and pricing. Could you clarify the methodology used to set the provider network pricing? Are we aggregating all hospitals into a single network with a baseline discount assumption, or are we segmenting them? When grouping the hospitals, is the discount assumed as a flat average across the entire network, or is it tiered based on hospital classification and negotiation power?
So for that question, there's what's practical, and there's what's commonly done, and then there's best practices. I apologize about the microphone. I'm not used to this. Best practices is you do it separately, contract by contract. So you've got a contract with this hospital system, you got a contract with that hospital system, maybe you have a separate contract with a clinic. You do that analysis separately for each provider system. So that's when I talk about granular level data. You do it at the most granular way possible. That's because if those contracts say change, okay, we've just make an optimistic scenario. We got a 5%, a big 5% bigger discount from this hospital system. How does that impact our expected claims, and how will that impact our premiums? If you're using an average, you can't really tell. If you've got the granular level analysis by provider system, then you can do that analysis. And I say that, and I don't mean to sound oversimplified. Large health plans in the United States will have entire department separate from the actuarial department, an entire department whose job it is to analyze the financial impacts of their provider contracts. They're typically called the healthcare economics department within a health insurance company. The healthcare economics department is often led by a senior actuary, but it's not an actuarial department. So that's an excellent question that came in online, and but I would say, I mean, when you in reality, not every insurer has the resources to develop an entire department dedicated to just doing that. So in reality, you are probably constrained by your resources, constrained by your time and your staff. So I would say as detailed and granular as possible and practical is better. When the problem is when you do averages, those averages can get out of whack when things change. They may be fine for the period of time you were looking at then, but things can get out of whack. One hospital system could start seeing more patients or fewer patients. So there's a risk to doing it that way, but as I said, you got to do what you can with the resources you have. Any other questions? Any questions from the audience? I would say during my meetings this week, I had the data stuff come up more than once, probably more than twice. So I was kind of thinking there would be some conversation on it today. Maybe it's too difficult a topic to talk about. If anybody has any just comments or observations they'd like to share about their experience on developing and maintaining a robust healthcare claim database in your company, I'd love to hear about those too. Doesn't necessarily have to be a question. All right, well.
Tom, there's a couple of other questions coming online. Question number one, besides the gender and age, what are the other popular pricing indicators being used in the States? especially given no regulatory constraint of discriminations. Is that true? The question is, besides the gender and age, what are the popular pricing indicators used in the States, given that no regulatory constraint of discriminations?
Right. Well, this, varying rates by age and gender is generally not viewed as discriminatory because it's actuarially justified. There's shifting public sentiment on that, though, in many jurisdictions. In fact, I think across the United States now, there is no variation in rating by between male and female. Is that you have a rate of a blended rate across both. And what other rating factors are there? What do you think? I mean, I mentioned that the industry. So if it's an employer group, what industry they're in can sometimes be a driving factor. I don't see that used in individual business. And then the other thing would be if underwriting is permitted and premium rates allowed to be adjusted according to local regulations, which they're not in the US, but some indication of some of health status. And there's a bunch of different ways that can do that. There are commercial products you could buy, which like assign a point value to each diagnosis that an individual has, and then you compare that point total to an average, that sort of thing.
Okay, thank you. Next question. For the US experience, in case of medical costs rising significantly in the last decades, besides more frequent pricing new products, what pricing approaches might be applied to deal with such rising cost base?
Sorry, applied in addition to what?
What pricing approaches might be applied to deal with the medical inflation?
Well, that's a huge question. When I talked, I would say the primary one, and this isn't a pricing strategy, it's a company strategy. The primary technique used to manage healthcare cost trend risk is by passing some of the cost risk to the provider groups. And I understand that that's not what's done here, but the question is about what happens in the U.S. And having the provider systems have some skin in the game, some financial stake in the outcomes of the insurance program, while still maintaining their standards for quality and clinical appropriateness. That is a thing that seems to be working a bit, working pretty well. It's not perfect. And I'd say there are a lot of efforts underway right now in the healthcare market in the United States to look for other ways to mitigate trend risk. Many of them unproven or untested. But the provider payment structures is the main one. And that's why they started to begin with. Like that was the driver for what, I mean, that kind of evolution in provider payment structure in the US really started really got serious in the 1990s. And I've watched it evolve considerably over the course of my career. But it was medical trend and people being really frustrated with medical trend that drove that evolution.
I'm not sure if I understand this question really well, but we'll leave it to you to decide how much in the States, how much percentage of disposable income are customers willing to pay for their healthcare insurance plan? Is this percentage varied by any factors?
I get the question, and actually, it's a really interesting question. What the percentage is, I don't know what it is. There is, but there certainly is there's like a percentage where, and it's not as simple as what they're willing to pay. So the question is asking about affordability of health insurance and how the market perceives the affordability, and it expresses that question in terms of percentage of disposable income. So income after you pay your taxes, income after you pay your rent, um, income after you buy food. And that percentage, I mean, I'd have to take a wild guess, but it's, I'm gonna guess, I don't know, between 10 and 20%. That's my absolutely totally unscientific guess. But I mean, but even at those percentages, people complain, and you see articles in the newspaper. Joe and his family of 4 have to pay this much for health insurance, and they don't have much money, and look at how hard it is for them. Was there a second part to the question?
Is this percentage varied by any other factors?
Well, right. The higher your disposable income, the lower the percentage goes, right? Because health insurance is more or less a fixed amount, so there's leveraging involved. If you really want to go into the weeds and how the U.S. works, for the people who are low income, like as defined under the law, the very poor get free health care. And for those who are not below the very poor threshold, but sort of in the lower threshold, but not all the way low, they can get government subsidies to help cover the cost of their health insurance for exactly the reasons that the question is getting at.
Next question is on underwriting selection and waiting period. How do they influence the data preparation process? How should their effects be reflected in the initial claim assumptions? And is the adjustment factor the standard approach?
I missed the middle part. I think I got the question, but I missed the middle part.
How should their effects be reflected in the initial claim assumptions?
Right. Right. So it depends on how much data you have. If you had a wonderful, huge abundance of quality data, you would segregate the claims during the waiting period and evaluate them totally separate. So this is what it looks like during the waiting period. This is what it looks like after the waiting period. I think they also asked about underwriting. So if you've got some sort of simplified medical or medical questionnaire or underwriting, that underwriting will have a positive selection effect that will then wear off as policies get older, and so you can segment your claim analysis by duration. That's hard to do because at that point you're splitting your data into little smaller and smaller pieces. Did I answer the whole question?
Yeah, I guess so.
Okay. That it?
Yeah.
None of those questions have to do with data. Okay. All right, let's move on. So I'm gonna pivot now to talking about checking reasonability of results. I've just gone through a relatively high level, the best I could do in a couple hours, the technical approaches to actuarial pricing for health insurance. And as I alluded to in one of my earlier remarks, you can't just blindly accept model results. That's, in my view, irresponsible and unprofessional. And this matters for a number of reasons. First of all, no pricing is ever perfect. We have a line we attach in my firm to all of our client work that says essentially something like actual results are certain to vary from expected, because an actuary's projections never are 100% correct. And so no pricing is ever perfect. And as I said, in health insurance, it's common that you've got to use a lot of professional actuarial judgment in setting your model. So reasonability testing ensures that your results are credible and reliable. Maybe ensure is a little too strong, but it's a step towards ensuring that your results are credible and reliable. And when this is done well, it can support sound business decisions using analysis that can be relied on, not just by the actuary, but by management. And as such, it can build trust within company management and other stakeholders in the work of the actuaries. So here's a summary of what I'm going to talk about in terms of some key reasonability checks. This is just kind of standard approaches that people will use. I'm going to talk about all of these in more detail one by one, except for one of them. But the key checks are comparing to benchmarks. Are trends reasonable, consistent? Doing sensitivity analysis, back testing, and kind of overall reasonableness checks. Item 4 here, back testing, I'm not going to talk about any further. It just means if you have an actuarial model you're using in pricing, applying it retroactively to see how close it gets to what actually results actually happened. There's really not much else to say about that, but it can be a useful tool. So comparing the benchmarks, and that means you have to find benchmarks or have benchmarks, and industry data, if it's available, can be a valuable tool in doing a general reasonability check. And the key here is if your results, meaning the numbers that came out of your actuarial modeling, if those results are materially higher or lower than industry benchmarks, external experience, it doesn't mean it's wrong, but you should be able to explain why your rates, your numbers are so different, and there might be a good reason for it. In addition to industry data, your company's own historical experience in related policies, similar policies, and likewise can be a good thing to check against. And again, they don't have to match, but if there are material variances, you should understand why that is and be able to explain them in a way that makes sense. And by explain, I don't mean make excuses for. I mean, okay, this variance exists for the following reason. That makes sense. The variance should exist. We're okay. And then finally, I want to talk about concept of peer review. And I'm getting kind of less into actuarial technical work and more into actuarial management. But a best practice, in my view, in all actuarial work, including actuarial pricing development for health insurance, is peer review. So peer review means another actuary, somebody qualified and knowledgeable about the business, but who did not do the work, reviews your work and ask questions or, determines, is this reasonable? Does this make sense? They might check for calculation errors. Who knows what kind of questions they'll have. But it can be a really good, first of all, quality control point, but also a reasonability check on the judgments that went into setting the assumptions. My firm has got strict approaches to peer review. It's mandatory, and if you do not follow peer review processes in my company, you don't get promoted. It's that simple. That's how big a believer we are in the power of peer review. So trend consistency, we've talked about trends already, but obviously in health insurance, claim costs go up. This happens for a number of reasons, beyond inflation, like new medical technology, so on. And so it's important to evaluate year-over-year trends. And it's important to understand if the trends you're using in your pricing are consistent with historical. So earlier I talked about comparing to benchmarks in terms of claim cost pricing levels and being able to explain difference. But in addition to the absolute levels, the year-over-year trends should be checked against something internal. Maybe there's an external benchmark that's available, and variances be able to explain. Are trends consistent with recent experience? And if not, why not? Are there outliers driving results? And so I'll talk about trend analysis later. Outliers being an important consideration. Sensitivity analysis. And I talked about this a little bit earlier, but what happens if you if you change certain key assumptions? And that's particularly important especially valuable for, I'll call vulnerable assumptions, where you've had to exercise a fair amount of professional judgment in setting them, meaning the potential for there being an error or being off is greater. And so we see typically structured a sort of a robust structure, a standardized structure, where you might have a set of adverse scenarios that you're going to test, and you just say, okay, what if my assumed trend is too low and I add 4 percentage points to my trend assumption? What does that do then? You might also though test positive scenarios, and then also just some sensitivities around in the middle, and then developing a range of possible outcomes will give you a sense of the inherent risk in the product and the inherent risk in the pricing. Reasonable checks are just a common sense review of the pricing result analysis. Do the numbers your model has generated in the pricing, do they make sense? So do the claim frequencies make sense? Is the average cost per claim by type of claim, is it plausible? If you do an analysis and it shows an average cost per inpatient hospital day is much lower than anything that happens in reality, you've got something wrong with your model. You need to check it. Also need to be sure that results make sense in the context of population demographics. If you're expecting a higher age of enrollment, for example, one that you don't have built into your own experience, your own claim assumptions, but you have reason to believe that your enrollment will be higher age, have you captured that in your pricing? And then finally, our work has to be compliant with regulatory constraints. And so if there are material regulatory constraints on the ways used to set premium rates, you need to be very sure that you are in client compliance. So ultimately, these review processes are intended to assure you and your management that the proposed pricing makes sense. And that it can be explained outside the context of the actuarial models in ways that seem reasonable to others in your company. And this will include presenting the results of your analysis to the broader management team to allow them to understand the pricing, ask questions. I presume somebody would challenge it. It's a classic dynamic in health insurance that the chief marketing officer always thinks the proposed premium rates are too high. And the chief financial officer usually thinks that the proposed premium rates are too low. And there's a healthy tension there, or at least it's usually healthy. And then finally, and I've said this a few times now, but I want to emphasize, no pricing is ever perfect. Actual results will always vary from expected. So after you're done with your pricing, you've done your reasonableness check and you're implementing, it's important to continuously monitor experience as it emerges so you can see how it's going and refine the pricing going forward. And in a little bit here, I'm going to talk about evaluating emerging experience. So I'll pause there for questions.
These are questions from online. I think it's a bit earlier, but should health insurance pricing vary by region, income level, education level, or other factors where the data supports it?
That's a tricky question because some of that is a public policy decision that is not the actuary's realm, but the government's realm. And I'll use a sensitive example from my own country. And in the United States, Black people have traditionally a different claim cost level than white people. Also in life insurance, Black people have a different mortality rate than white people historically. But nobody rates differently between Black and white people because, first of all, that would be perceived as a disaster publicly, and second of all, it's illegal. So when you get into these other things, which are not nearly as politically sensitive, obviously, but varying your rating by income level, say. I guess my point is just because there's actuarial evidence to support the claim differential does not necessarily mean it's the right way to differentiate between rates. And so it's it's the question is posed is not really an actuarial question. It's more of a how does the society want to govern itself, and what does it want its policy to be? In the U.S., rating differently by geographic area, different parts of the country, normal. Everybody does that. We're a big country, very diverse geographically, and costs from one area of the country can vary a lot from other areas. There are parts of the country that are twice the cost of other areas for no reason other than medical practice patterns and so on.
The next question is the practice of making adjustment to actuarial assumptions annually based on experience appropriate. How much credibility should we give to one single year's experience for adjustment of assumptions?
Depends on how many lives you have. So credibility theory, which is basically an application of the law of large numbers, the law of large numbers, the higher your sample size, the lower the standard deviation. If you have a large insured block like what I see in practice, if the block is big enough, all the assumptions will be reset every year. Hopefully, they're not radically reset because if they are, then something weird's going on. But if the block is big enough, then you're doing pricing from scratch, experience pricing from scratch every year. So it's not like you've got a model with fixed assumptions in it. It's more like if the data supports a change in the rates, then you are changing the rates. And this gets into what do you do with less than a robust claims data set. If you don't have that much data, then yes, you would mitigate that a bit. But like I said, I think universally true that claims pricing is opened up, unlocked, opened up, and revisited every single year. If the data is there to support it. I said at the outside of this presentation that health actuarial work is at heart data analysis. And this is the sort of thing I'm getting at.
Hi. I just have a question on the anti-selection. In life insurance, the healthcare is a rider on the main product. So the underwriting process is very it's like clear, and is the process is very very good. But in non-life insurance, the healthcare is standard alone products. So how, and I think that anti-selection is one of the key risks in the healthcare products. So how can we control what technique we can consideration in the balance anti-selection in the pricing model?
If I understand your question, let me read it back to you. So you contrasted life insurance industry underwriting, which is very robust, to underwriting in non-life, which is a little messier. And then you asked, is it what can be done better to underwrite? I'm not sure I got the final gist of your question. Did you get it, Jared?
Could you repeat the question, please?
Thank you.
I mean that how can we control the anti-selection risk? How we can, what's consideration to make the to reduce the anti-selection risk?
Yeah, well, that's not easy. The things you're already doing, like pre-existing condition exclusions and waiting periods, that is to design, to address adverse selection risk. But adverse selection is always going to happen because, like I said, people are making decisions, especially in individually written insurance. People are making a decision to buy insurance because they perceive value, because they perceive a need for insurance. And if they perceive a need for insurance, they probably need insurance. Other steps is in mitigating adverse selection risk really start to, when you get away from just underwriting, it gets really hard. There are like rate renewal strategies you can do that I've seen done in the past where, okay, you're going to close this block of business, and as they age off and they get, like, their claims will get worse because there's adverse selection, not just at issue, but at renewal every year, right? And just put larger rate increases through on the closed blocks and then open a new block of business. That's not a very perfect strategy, but it's one I've seen used in the past. Ultimately, to fully address, this is not going to answer your question very well, but it's my opinion. To really address adverse selection risk, you need government regulatory cooperation. And this is when I talked earlier about things like the government subsidizing the cost of insurance. If the government subsidizes people's premium rates, that changes the cost benefit equation, makes the cost go down, and so the threshold for benefit goes down in order for it to make financial sense. So that's an approach, and I'll talk about, and this is an extreme example, but in the Netherlands, in Europe, in the Netherlands, they have a market where it's like a federal scheme, it's like a government scheme, but it's all private insurance. So they have everybody in the Netherlands is required to buy health insurance by law, and they enforce it in an effective way. So when everybody buys health insurance, there's no adverse selection risk because everybody has to buy it. But where the adverse selection risk may exist is who chooses this private company versus who chooses that private company. So you get a skewing of the risks amongst the health insurance carriers in the market. And to address that, there's a concept called risk adjusters, which is pretty complicated, but they use it in the Netherlands, they use it in Ireland, certainly use it in the US, and probably in some other markets too, where through an algorithmic process, each insurance carrier in the market is assigned a risk score. This is the average risk of the population you have enrolled this year. And when there are differences, if I have a higher risk score and my competitor has a lower risk score, the government actually mandates a transfer of premium money from the lower risk score to the higher risk score insurance carrier. And the notion there is to try to stabilize the risk across the different carriers so that they want to continue to participate in the market. At that point, I've gone pretty far afield from what is possible today in Vietnam. I understand that. I guess it's my way of saying there are no easy answers without making radical change. All right. Another question. No more questions online? We're moving through this presentation at a pretty good pace. Let's talk a little bit about evaluating trends and emerging experience. And this is sort of two sides of the same coin. And so I'm going to talk about some items regarding how to evaluate claim cost trends in health insurance, how things change over time. Again, as I noted, I'm speaking generically. I don't have experience in the Vietnam market. And my colleague, Pang Chai, will be addressing us after lunch to talk about his experience with that in Southeast Asia. So reviewing your emerging experience over time is important. And because as I mentioned earlier, no actuarial pricing is ever perfect. And in health insurance, it could be particularly fluid. And continual monitoring of trends and experience is essential to effectively managing health insurance business. And there are a number of reasons for this. First of all, continued accurate pricing, and by accurate, I mean actuarially sound, is necessary so that the product is sustainable. And products won't be sustainable unless you continually review experience versus your pricing assumptions. And Jerry, I'm thinking back to the question we had online earlier about how often do you unlock or change your model assumptions? And the answer I gave was always, because as I mentioned, unlike certain other types of insurance, health insurance is so fluid and dynamic and changes quickly over time that's really the only way that works. It is common for an insurer to find themselves in a situation where they have more adverse experience than they anticipated, and being able to respond quickly by evaluating your ongoing experience will allow the company to respond quickly and potentially mitigate adverse selection risk and financial losses down the road. And finally, the products, as I've noted, is the market component. Your products have to be compliant with government regulations, and they have to be competitive. And this is not possible in health insurance without continual refinement of the model. All right, so what is trend analysis? And I'm going to walk through a few points here. So the definition of trend analysis is that we're looking at what our historical trends have been. And the purpose of that is we're examining changes in historical costs over time, so that can be an input of understanding for when we project our future costs going forward to the coming pricing year. Medical costs go up not just because of inflation, but because of intensity. The services that are provided in medical care change rapidly over time. This is one of the main reasons why health insurance is so much more fluid and dynamic than other types of insurance, is that it's not static. It changes rapidly. There's medical technology, new prescription drugs. It's always undergoing an evolution. Demographics are a driver here, the aging of the population, also the shift between men and women. Regulatory is important because there are, from time to time, new laws and new regulations, and that might include limitations of characteristics used in underwriting, all of which affects our claim cost levels and therefore affects how our trend emerges. And then again, medical utilization, I alluded to this in the first one, but there can be an increase or decrease in the frequency of certain services, or there could be a shift of services. So years ago, if you look at claims at a very detailed, granular level, we saw, I'm talking like 20 years ago, maybe 30 years ago, we saw the utilization of X-rays go down because many of them were being replaced with CAT scans and MRIs, and that utilization went up. Overall, radiological imaging utilization was about the same, but the mix of those services, and obviously MRIs and CAT scans, are much more expensive. When I talk about emerging experience, and just real quick here, emerging experience is an evaluation of claim costs in, I'm going to use the phrase, in real time, or as close to real time as possible. So looking at what is happening with your block of business on claims experience, enrollment data, capturing immediate short-term variations in experience that aren't captured by or seen in long-term trends. And examples can be, if you've implemented for this year's policy a new benefit plan with a higher deductible. If the deductible is higher, we ought to see a downward shift in our claim cost levels, all of it being the same. That ought to show up in the benefits and in the claim costs, and you need to check that. And I mentioned also like new technologies, new drugs. When COVID happened, that had a profound effect on emerging experience. So what are the data sources for evaluating emerging experience and trends? There could be industry benchmarks, and this is actually in the US fairly common. My firm, Milliman, publishes a trend index, a Milliman healthcare trend index, every quarter, which is purchased by our clients to help them inform their trend levels. Of course, as I've alluded many times here, in trend analysis, the historical claims data is also that's your best source of information if it's there, if you have it and it's usable. Of course, your enrollment and demographic data, provider and pharmacy data, and then any regulatory changes. So changes in regulations that get implemented over time may very well have an impact on your claim cost levels and on your claim cost trends. I'll stand because I need to stretch a bit. Been a long morning. So the first step in analyzing trends and experience is get your claims data in order, right? And this is I talked about for pricing models, evaluating emerging experience is very similar issues. You've got to validate your data and clean your data if necessary. Adjust for outliers and claim lag. And claim lag is interesting here. I haven't really talked about that. But your claim experience database will be claims that you've paid. So it's paid claims. We all know as actuaries, paid claims are not the same as incurred claims. So you've got to make some sort of adjustment for that in evaluating your experience. Outliers are a tricky thing. I think I'll talk about this a little bit later, but outliers will happen from time to time. And you need to understand your outliers to make sense of your trend as it emerges. And a key point here and this is kind of different from a pricing analysis, when you're doing a trend analysis or emerging experience analysis, it's really important to ensure data consistency over time. So, and this is because we're measuring changes in claim costs over time. So if you have data inconsistencies in one period of time to another period of time, inconsistencies meaning we're not capturing everything in the past, or we change the definition of how we're capturing claims, that can lead to misleading results. Maybe that's obvious, is that if your data is defined and captured in different ways at different points in time, that may not be an accurate measure of trend. And finally, I'll note that to the extent possible, again, this is requires a good data set, but segmenting your experience data into various cohorts can provide a more refined and detailed analysis. Segment by these different things I've listed on the slide here. That's best practice. You do run into issues here because you're measuring trends. So you're measuring one change one year over another. Statistically, the credibility required to get an accurate trend membership, you need more data than you do on just getting claim cost levels. And so you get into credibility issues if you segment things too far. So doing a trend analysis, in the simplest way of looking at it, this is a simple year-over-year change. What were our costs per unit of exposure last year? What are our costs per unit of exposure this year? How much did it change? If you do that on a monthly basis, which is sort of the normal approach for health insurance companies, they have an actuarial department that is doing this every month. You're going to have noise in the results because they'll fluctuate up and down. So you need to, one common technique is to do a rolling average over time to smooth out fluctuation. And you'll want to be aware of and adjust for external factors. So when you're trying to understand and do an analysis, what is my underlying base trend? You should remove the impact of various changes that will impact the changes in claim costs, but are not indicative of underlying trend. And that would be, as I said, one-off events, plan design changes. I made this example earlier. If your deductible goes up, so your claim costs will shift down a bit, that's not trend. That's a change in benefit plan design. That's not your underlying trend. And so forth. Provider network changes is important too. It's important to understand. So for the emerging experience analysis, very similar. And here, what you're doing is you're looking at your own experience and comparing those to recent historical trends, looking for anomalies or new patterns in claims. And as I've alluded to in a few other points, using credibility weighting here can be pretty useful. So doing this experience analysis and trend analysis, what is the application pricing? And I questioned earlier, kind of already addressed this, but health insurance pricing is constantly, continually being updated because you need to incorporate most recent trends and experience into the data. You also want to scenario test as experience emerges to understand what's happening. Oh, and sensitivity test as well. Yes, sir.
2 questions just came. What should be given more weight when pricing next year claim? The trend midterm or the emerging experience short term? How long is the window for trend? 3 to 5 years, 10 years, or emerging 1 year?
I'll start with the easy part. Not 10 years. Because I've talked a little bit about how and emphasized how health insurance is very fluid and dynamic and changing a lot over time. Claims experience that is more than 3 years old is not useful, in my view. Simply not useful. Claims experience really needs to be based on the most recent couple of years. And when I say that, I'm talking about baseline, like claim cost level. Trend is a little different because it's measuring change over time. And it's important not to overreact and also important not to underreact. The right answer is to figure out what's driving your trends and then understand if that's, and then make a determination, is that likely to continue or not? That requires, again, quality data at a very granular level so you can go in and do some real detailed data analysis to see where those trends are coming from and try to get to the bottom of why they're happening like that. Trend analysis is simply an arithmetic exercise, is not nearly as valuable. I missed part of it. I get it? Okay.
Next question. What are the benefits of segmenting data by different parameters, such as region, when segmentation cannot be applied in pricing?
Right. It can't be applied in pricing, but it helps you understand. Did everybody understand the question? The question is, why bother to segment your claim analysis, your emergent experience analysis, your trend analysis, if you can't do that segmentation in pricing? Good question, and there's a good reason why. segmenting the analysis allows you to better understand the underlying dynamics of all the risks in your insurance block, and then it allows you to identify things to which it's particularly sensitive. And then as the mix of different things change over time, so it's just, let's say I'm insuring an insurance company is operating in a country with two regions, region A, region B, and region A costs 10% more than region B. It's my simple numerical example. And by law, the carrier cannot rate separately for region A and region B. But by doing the analysis and making sure like how that changes, and then you figure out, oh, look, region A is becoming more and more a part of our insured block compared to region B. That means your aggregate costs will go up, and you can build that into your pricing assumptions. And that's the reason to do it. So when you can't segment for rating purposes, you're essentially cross-subsidizing between different groups that cost different amounts. And understanding the mix of those groups. Whenever there's cross-subsidization across different groups, there's always a mix risk. So understanding that mix risk is why you do it.
Next question. Can you further elaborate how to apply credibility weighting on experience? Can you further elaborate how to apply credibility weighting on experience?
Yeah, I'll use a let me think. So as you're evaluating your emerging experience, if you have a very large block of business, that's fully credible. If you have a very small block of business, it's not nearly so credible. And it's more of a how much weight do you give it in your consideration of is it real or not? And it's not just the size of the business, it's the time frame you're looking at. So, and I mentioned earlier, it's common for health insurance company actuarial departments to be doing ongoing trend and experience analysis every month. Like that's their job. And but over those tiny short, like it's a rule, don't put too much stock into 1 month trend. But if it consists over time, then that's more material. So it's less of a formula driven credibility thing as it more is just an understanding of interpretation results. Okay, another question. So we're scheduled to break for lunch in what, 10 minutes? I'm gonna section stop here. So I think it makes sense to pause. Okay, so we're gonna break for lunch now. And we are gonna be back in your seats, ready to go no later than 1:15, because that's when Mr. Chai is gonna be joining us.